would say that, sir, is any malignancy causing it? The answer is no. This is basically a aqueous misdirection syndrome, also called as ciliary block glaucoma. Now, what are the important features that you should remember regarding the malignant glaucoma? As the word suggests itself here, there is a aqueous misdirection. First of all, in which conditions you can have a malignant glaucoma? Let's say patient has undergone a trabeculectomy surgery. The patient have very high intraocular pressure, not controlled on maximum medication. Now he has undergone a trabeculectomy surgery. So what is there is that because of this trabeculectomy surgery, there is a spasm of the ciliary body. Now this spasm of the ciliary body basically causes ciliary body to move or rotate posteriorly. Now when ciliary body rotate posteriorly, what would happen is that instead of aqueous humor coming in the anterior chamber, this aqueous humor would start collecting behind the lens. Okay, so there is a aqueous misdirection here. Can you understand? And this is why, this is because of the ciliary spasm. So the most common cause of malignant glaucoma is the intraocular surgery, that is the trabeculectomy. Though it can be there in any intraocular surgeries, okay, even after cataract surgery, even after penetrating keratoplasty, wherever you are touching the iris and you are near the ciliary body, this can cause a malignant glaucoma. Even in iridotomies, you have seen that in the literature there is a malignant glaucoma, but for your exam purpose, remember the most common one, that is trabeculectomy. So how would they give you a question? They would give you a question: a patient who is a 65-year-old patient, uncontrolled on maximum medication, underwent a trabeculectomy surgery. After undergoing a trabeculectomy surgery, the pressure is 55 millimeter of mercury, okay, and there is a aqueous collection in the posterior part of the lens, posterior to the lens. What is your diagnosis? Your diagnosis would be ciliary block glaucoma or aqueous misdirection syndrome. Now, what are the other features that would happen? Now, when this aqueous pocket would be posterior to the lens capsule, what it would do is it would basically push the lens anteriorly. Okay, now this would push the lens anteriorly, and because this lens is pushed anteriorly, the anterior chamber depth would be decreased. This anterior chamber depth, this would be lesser in the center of the anterior chamber as compared to periphery. Can you see here? Appreciate that lens is coming forward, okay, and whole push is axial from behind the lens. Okay, remember, when a patient is having a primary angle closure glaucoma, then as I told you in your Van Herrick's grading, that in that case the anterior chamber depth is shallow in periphery as compared to in the center. So that is how you can basically distinguish whether it is a primary angle closure glaucoma or this is a secondary glaucoma. So this is the major way through which you can basically identify a aqueous misdirection syndrome or a ciliary block glaucoma. Now, how would you basically treat this patient? So first of all, what you have to do is for management, you have to make sure that this ciliary spasm, okay, this goes away, because that is the cause that the ciliary body has basically mal-rotated posteriorly. You have to give rest to the ciliary body. And what is the best thing to give the rest to the ciliary body, that is your cycloplegic. So you have to use atropine as a cycloplegic. So sometimes they ask, even in the angle closure glaucoma, can you use a cycloplegic? The answer is yes. So if you are having a secondary angle closure glaucoma due to aqueous misdirection syndrome, in that cases you can give, or you should give, the cycloplegics to give rest to the ciliary body. This is the drug of choice there. Now let's say even after this the patient is not getting relieved. Still the ciliary body is posteriorly and there is an aqueous pocket which you are seeing on B scan. In that case, what the second thing you can do is you can do a hyalodotomy. What I mean by hyalodotomy is, this is my lens and this is my fluid pocket. So I would basically make a hole in the anterior hyaloid face, or if the patient is pseudophakic, what I would do is I would basically make a hole in the posterior capsule. So what would happen is, through that hole, that aqueous would go in the anterior chamber. Okay, so I am basically making a bypass of that aqueous to go in the anterior chamber. This is the basically treatment of malignant glaucoma. Many times after this, still you are not able to get a good intraocular pressure, no control of intraocular pressure. So in that case, last resort, what you can do is you can do pars plana vitrectomy. Okay, you can do a core vitrectomy and remove whole of the vitreous. That would basically give rest and would treat the condition. Okay, so this is all about the malignant glaucoma.